right, everybody, thanks for joining us. My name is Alex. I'm the lead coordinator for GoMe. We have an awesome talk planned today, so I'll turn it over to Nikos, who will introduce himself.
Hi there, guys. My name's Nikos. I'm based in the UK at the moment, so it's a good afternoon for me, but it's good morning, good evening, depending on where you are around the world. Thanks for coming. Just a couple of ground rules before we start. If we can ask you to keep your microphones muted throughout, and it's entirely up to you whether you want your video feed on or off, just so you know the video is being recorded, so you might get caught on our recording, which will go onto our website. We'll ask you to save any questions that you have till the end. If they pop up at any point during the talk, if you could put them into the chat box as soon as they arise, I'll collate them all as we go through and ask them on your behalf to Dr. El Sayed at the end. And when you put your questions in, if you can just add your name again and the institution where you study or teach, that'd be fantastic. I think that's it from me. Over to Annie.
Okay. Good afternoon, everyone. I'm Annie. I'm from Nigeria. I'm the African coordinator for GoMe. I'm sharing my screen right now. So welcome to today's edition of Wilderness and Emergency Medicine Lecture Series, proudly hosted by Global Organization for Wilderness Medicine Education. It's great to have everyone here. And you can follow us on Twitter and on Instagram at GO_WME. We'd like to have your follow, we follow back. So what we do at Global Organization for Wilderness Medicine Education is we create an educational platform where students and healthcare professionals can explore and interact with wilderness and emergency medicine. We also showcase diverse professionals and the impact that the way they can utilize careers in healthcare. So we create an international community of wilderness medicine enthusiasts and experts that are committed to promoting a diverse and culturally competent environment. So what this essentially means, we are providing a platform for people who are interested in emergency medicine and the field as a whole to be a part of something wonderful. That's what we do here at GoMe. And today we'll be talking about disaster medicine in reference to the Beirut port explosion of last year. And we've had wonderful sessions in the past. You can go to our website, you see some of those recordings. And the host for today, the person who'd be speaking today is Dr. El Sayed. So let me just read a brief citation about Dr. El Sayed. There's so much about him, but I think what stands out is an associate professor of clinical emergency medicine in the Faculty of Medicine at the American University of Beirut. He's also a American board certified in emergency medicine, has masters from Harvard and from Boston University. He served in many administrative and leadership positions. And today he will be speaking with us about the Beirut port explosion and how it was handled. Please, with a warm virtual hand clap, let's welcome Dr. El Sayed. I'll stop sharing now. Welcome, sir.
Thank you, Annie, for the introduction. Thank you, Alex and Nikos, for the invitation. I'm really excited to be giving this talk. I wish I was speaking about a more happy topic, but I'll share with you what happened. So are you seeing my screen? Okay, perfect. Yes. So I'm sure a lot of you heard about the explosion on August 4th. It was all over the news, all over social media. And really, it was an event that will always be remembered as one of the most catastrophic events that Beirut ever witnessed. So I'll just give you a brief description about our setting and where this happened. I'll discuss mainly the disaster event and the response at the hospital level and at the national level, and some of the lessons learned from that event. So on the right is the main blast. You can see it was a chemical blast, and you can see different colors of chemicals after the explosion. You will see the destruction in a video that I'll show later on, and I'll caution you about the viewing that video. You've probably seen it over the media, but it's every time we see it, it makes us remember that day. And there are things that happen in your career that you will never forget. And this day was one of those days. So just briefly about Lebanon, a lot of you know where Lebanon is. It has a population of around 7 million. Probably something that most of you are not familiar with is that it hosts a huge population of refugees from Palestinians in the past, and more recently Syrians after the Syrian conflict. So refugees are around 2.4 million out of its overall population. The health sector in Lebanon is mainly private. So it has around 178 hospitals, mostly private. And the public system recently evolved with the COVID pandemic. Over 45% of population is uninsured, and this recently increased. I'll tell you why. Our pre-hospital system is relies mainly on volunteer services. The EMS agencies are mostly Red Cross, and there are the national governmental agencies, which are also based on volunteers. The level of care that's provided in the field is usually at the basic life support level. And there curriculum for pre-hospital. So it's initiatives by NGOs to train pre-hospital providers and to maintain certification at the national level. And this is where I work at AUB. If you've visited AUB, it has one of the most beautiful campuses in the Middle East. It's an old university. It has graduated over thousands of physicians over the years. We have a very old medical school that has, and everywhere you go in the US and across the world in different medical schools, you will see that someone graduated from AUB. So the center that I work at is AUB MC. It is the largest tertiary care center in Lebanon. It is considered the referral center for Lebanon and for the region. Our ED is the largest tertiary care center ED in an urban setting in Beirut. It sees around 60,000 visits per year. Most of the faculty that work at AUB-MC are usually board certified, and in the emergency department, they're mostly ABAM certified. We have a residency program that's ACGMEI accredited, and we graduate around 4 to 5 residents per year. And we also have different subspecialties within our department: pediatrics, toxicology, EMS. We have ultrasound and global health. Our faculty are involved with international projects. In 2018, our institution purchased Epic as an EHR, and I'll tell you why this is important later on. And we labeled it, we branded it as AUB Health, and it's been working extremely well since. And I'll tell you the challenges that we faced during the disaster. So Lebanon is not, it is very familiar with the conflicts and mass casualty incidents. So for 15 years, we had a civil war in Beirut and Lebanon, and it lasted from 1975 to 1990. We also had several armed conflicts in 96, 2006, 2008. We had several blasts and really targeting civilian settings, 2005, twice in 2007. I joined back Beirut in 2011 after training in the US in Boston. And since then, I personally responded along with my colleagues to more than 7 blasts, mainly 2012. 2013 was a very busy year, and it was a spillover from the Syrian conflict. We had the last blast before this one was in 2018. Also, the spillover from the civil war in Syria resulted in refugees, extreme challenges to our healthcare system, and spilling conflicts into Lebanon. In 2019, we had a massive financial crisis that resulted in riots that are continuously happening since 2019. And on August 4th, 2020 was the big explosion. So this is the setting where we're working in. So there was an economic crisis, there was a healthcare crisis related to this. And at the same time, in 2019, the COVID-19 pandemic hit. going back to the economic crisis, it really affected the whole setting in terms of riots, protests. Our staff and the healthcare sector was really bombarded with regular casualties from the riots and protests. There was a shortage of healthcare personnel related to the financial crisis and people emigrating to back to the countries they were residing in before moving back to Beirut. Shortage of medical supplies and medication related to the exchange rate between the Lebanese pound and the US dollar. And then there was the reduction at the same time in terms of coverage from insurances and increased healthcare utilization in terms of visits. And with the reduction related to vaccinations and prescriptions, people were trying to access healthcare in different settings. And this was creating a lot of strain on the healthcare sector. And then the COVID-19 pandemic hit. It hit every country, and Lebanon faced extreme shortage of PPEs, ventilators, and lack of readiness at a national level. We were not ready for a pandemic this size. No one was ready, actually. Even the most prepared countries were not ready. Fortunately, we had an early airport closure after the first case was identified in Lebanon, and an early lockdown that prevented the early escalation of cases. So we had a late peak compared to other countries. And as you can see, Lebanon compared to other countries, our peak started, our numbers started really rising in March. And in August, when the explosion happened, it was, we were really hitting high numbers of daily COVID. So this again goes back to the challenges in the setting that we were working on during that disaster. Our overall in October, we had around 71,000 cases and 565 deaths. Our mortality rate compared to other countries was 0.8%. And on August 4th, we had over 5,062 cases of COVID. So, but this gives you an idea of what environment we were working on and how usually you prepare during disasters. And the most important phase in the disaster cycle is preparedness and mitigation. And really, if you can see the timeline and the historic factors that were in play, you realize that this country was not prepared for another event. So on August 4th at 6:08 p.m., I was working in the emergency department. I was doing my regular shift, which started at 4 p.m. We were seeing a lot of COVID cases, and then this happened. So this happened at 6:08 p.m. We heard an explosion initially, followed by a blast and a blast wave that threw everyone to the ground, destroyed partly the infrastructure in our hospital, and I'll tell you where our hospital is located with regards to the blast site. But everyone realized at that time that something major happened. I was in the emergency department, and the blast actually shook the ground and threw me on the ground. I walked outside to see. I thought initially that it was a oxygen explosion within the emergency department. I walked outside, and then another explosion happened. So at the time, my wife was working in her shop in Beirut. I called her to check on her, and I told her, I'm alive. An explosion happened in our hospital, and I'm alive. I'll call you back. So then her response was, no, the explosion just happened here, and I'm injured. At that time, I realized that there was something bigger than what we expected. It was related, just to give you a brief overview of this blast cause, it was related to 2,750 tons of ammonium nitrate, which were unsafely stored in the port since 2014. This is a fertilizer that's widely used with additives as a blasting agent. There have been previous explosions in different cities that resulted in mass casualties, including Texas City, Oklahoma, and Tianjin. but they had the smaller amounts of explosives. And there was an EPA cautionary statement issued regarding the hazardous component of this chemical long time ago. So this is the blast area, and if you can see, it's at the port of Beirut. The heavy damage was, this is Beirut. The heavy damage really reached distant areas in Beirut. And this, you can see the source of the explosion. And in red, you can see mapped in dark red, the areas that sustained heavy damage. It registered around 3.3 on the Richter scale for earthquakes. And this is more closely looking at the blast. This is the blast site in the port. And you can see all the hospitals are within the close radius for this for this blast. So our hospital is this one, actually. These hospitals were destroyed, all of them. And these hospitals sustained heavy damage. Also these were safe, actually, because there is a hill and then a descent after. So you can see that all of the hospitals in this area were really affected. And this really gives you an idea of what happened to the healthcare sector immediately after the disaster. So over 190 deaths resulted from this blast, more than 6,000 injured and 300,000 displaced. 8 hospitals were affected, 4 were heavily damaged and 4 became non-functional. Over 2,000 physicians' offices and clinics were affected. The largest national stockpile of medications was partially destroyed. This was located next to the port. Also, a heavy stock of medications was located at the port. It was completely annihilated. 17 containers of medical supplies were also destroyed. The estimated damage resulting from this blast was around $15 million in direct damages. So previously, I had described the national response to mass casualty incidents in Lebanon, and this was in response to different types of MCIs, mainly related to an airplane crash, collapsing building, and a capsized boat. This was back in 2013. And the reason we described that is because we were dealing with unfamiliar MCIs. We were trained and we were familiar with MCIs related to conflicts and blasts, bombings, but we were not familiar with how to respond to more specialized types of MCIs. And at the time, we proposed a revision of how the coordination should happen, how the communication should happen, and how we should follow a similar system, similar to the incident command system that's placed in that's in place in most countries and mainly in the US. So we proposed that the incident command center be led by the Lebanese army, and this happened during this national response. However, the damage that really affected everyone, including the army, the EMS agencies, the hospitals, all responding agencies, really was beyond imagination, and it really impacted the overall response. So this is what we saw. I mean, imagine yourself working in a hospital and then having this blast destroying the whole radius of the whole city that you're working in. It's similar to a mini earthquake. And you start seeing patients and casualties arriving immediately from neighboring buildings. Walking. Some people were carried by their family members. Some people were carried by random bystanders on streets. People were transported on motorcycles. I mean, the earliest victims arrived walking, and the other victims, the really most severe cases, arrived by motorcycles and by ambulances and by private cars. You can see the army also collecting injured from the street and taking them to hospitals. You can see in the left lower corner, physicians treating patients outside the hospitals because most of the emergency departments were destroyed. So they had to, at the same time, check on their relatives, check on their family members, and at the same time, try to address the victims' needs without much resources. So at AUB, we had worked and drilled and trained on our disaster response, and we developed it over several years. And we eventually came up with two levels previously. One called partial disaster activation, which really activates most the essential resources in different departments. And the full disaster activation was activating the overall hospital staff. So it was activated 10 times in the last 9 years, mostly related to blast and riots. And the ED was color-coded, red for really high severity injuries, yellow for moderate, green for minor, and black declared dead based on the triage. So one of the challenges that I faced previously in the past is related to how do you triage patients in the emergency departments when you don't have a very organized pre-hospital care system. And the fastest one we could come up with was the care flight triage protocol, which we modified because imagine yourself standing at the door of the emergency department and then immediately seeing 10, 20, 30, 50, and 100 victims arriving. You need some sort of a triage system to do this. A lot of physicians who are experienced, they rely on just slight screening, visually screening, but sometimes you have to use a more standardized way, and our nurses were trained on this. So this is a brief overview of the triage system that we use. It really it's similar to all the pre-hospital triage protocols, and it addresses pediatric and adults. I will send you this. I'm not going to go into details, but it mainly assesses for ability to walk, ability to obey command, assess for pulse, and then for response after providing rescue breathing. So if they do not respond to rescue breathing, then they're declared unsalvageable in that period. For pediatrics, we try to provide rescue breathing, and then if they do respond, they're red. If they do not respond, they're declared dead. That's why. So most of the systems really do not allow you for triaging when you go to scene, but not for patients incoming to your ED. And when you're receiving patients, you have to be really quick in terms of assignment and in terms of letting them into the emergency department. So at the time, I told you I was working in the emergency department. So I ran to the corner after speaking to my wife, and she told me that the blast happened near her location. So I ran, and this is a picture I took immediately after the blast at 6:09 p.m. I think. And I look there and I see this huge smoke, orange smoke. So I ran back to the hospital, and inside the ED, I tried to activate the disaster response code, but the system was down. So I ran up to the communication center, which is on the second floor, and I told them to activate this. So we immediately activated the protocol, which really sends a paging message to everyone who works at AUBMC that you are needed. And within 30 minutes of this, really, we had 100 casualties received. Most of the casualties arrived within the first 3 hours, but then they continued to trickle in by ambulances, by private cars. Really, we treated over 500 casualties. Most of them were discharged home. 104 were admitted, mostly to regular floor. We had 31 went to ICU and 21 went straight to the OR. We had 13 who arrived dead on arrival, and they were sent to the morgue. We had 22 patients who required endotracheal intubation in the ED. So imagine usually we stock for 3 RSI rapid sequence intubation in terms of medication equipment, 3 simultaneous one. And in this scenario, we had to do 22 intubations immediately. So our anesthesia colleagues were there, but really every physician was busy trying to care for patients and trying to do life-saving procedures. So our ORs, we had 68 cases operated on within the first 72 hours in 10 operating rooms. The first 6 to 8 hours, we had 17 surgical procedures, 8 craniotomies, 3 limb saving surgeries, 2 abdominal traumas, 2 ophthalmology, ENT, and then thoracic, which was a penetrating thoracic injury one. So these were the main, this gives you an idea about the types of injuries that we saw. And you can see during blasts, we noticed that most of the injuries usually affect the head and neck. And this is very common from flying shrapnels and flying debris and from blunt trauma. So you see that recurrently in any blast, and I'll show you more. So if you look at the picture on the right, what do you notice? You notice that the all the windows are missing. So that gives you an idea that everything was really, and you saw that blast wave, it just destroyed all the windows across all buildings in Beirut. And it threw heavy equipment and heavy furniture on people and heavy windows, window frames on patients. So we had patients from all ages, neonates to over 90. The worst scenes were really mothers and fathers carrying their neonates and coming with unconscious babies, and that was really traumatic to see. And everyone had the fears in their eyes, and it really was. And it was really hard to tell someone to go to another hospital because we did not have the capacity to treat anymore. So we saw more penetrating injuries than blunt injuries, mostly related to glass and debris. We had a lot of patients with laceration. We had also blunt trauma to head and neck. As I said, head and neck injuries are very common in blasts. Upper and lower extremities, so people trying to protect their face if they had a chance, or trying to protect their head or their eyes, they end up with upper extremity injuries. And a lot of penetrating torso injuries. Complex wounds were very common, so you could see vascular injuries, patients bleeding, wrapped with wrapped towels on their heads or hands or necks. And really, it was all, the whole scene was bloody. This is the entrance to our emergency department. And you can see immediately when you look at the ceiling, you can see what type of setting we were receiving all these hundreds of casualties in. So the main challenge was really the facility structure damage and the large number of casualties that was received within a very, very, very short period. So as I told you, we had, this was our first mass casualty incident after transitioning to a complete EHR system. Previously, we used to use a fully paper charting system with partial computerized order entry in terms of labs and tests. But then we transitioned to a full Epic system. And Epic, really, when we were implementing Epic, we were discussing with them their experience with mass casualty incidents. And this was a huge focus area for us as an emergency department in terms of how do we streamline Epic workflows to allow for receiving large casualties. And this was really the first time Epic was tested in a mass casualty incident this size in any institution across the world after this event. So that's why really patient registration and tracking was, we had designed a very streamlined process in terms of having ready charts for casualties. We had at any time 100 casualty ready with bracelets available to be handed out to patients. And when you scan them, you immediately activate the chart. But what happened is we received more than 100 casualty. And at the same time, the system was overloaded with the number of patients that were being registered, so it became slow. And really, we had previously tried to speed up patient identification and rely on mass casualty records without identifying the patients. And this became a really major difficulty in terms of knowing what's the name of the patient, identifying patients, and then tracking them. Security and crowd control is always an issue with disasters. And with this one, it was a really major difficulty. One, because most of our security personnel were injured. And two, because really it was very hard to control any access entry points in terms of entry and exit, because everything was in terms of doors were destroyed. And really, the huge number of casualties and patients was overwhelmed security. So we had to request the army to help us control the crowds. Um, and imagine also yourself being working in that setting and then seeing a lot of friends, colleagues, family members coming in injured. And that really made it really hard for all the physicians, medical students, nurses, everyone who was working, really seeing their injured family members coming in and trying at the same time to respond to that disaster was really very challenging. So as I said, patient identification was also a challenge because we received a lot of unconscious patients and patients who were dead without any identification papers. And that created a challenge afterwards because patients were, people were looking for missing relatives, and they would come into the emergency department and they would try to show you images, pictures of their relatives or ask you about their names. And in this scenario, it's very hard to, one, recognize casualties because they're really severely injured. And two, because really we did not collect names initially, it was really difficult to try to collect and register names. And most patients arrived without any ID cards because they left their houses. It was 6 p.m. Everyone was at their house and they left it in a way that's really rushed, and it wasn't planned, and really it was unexpected. So no one was carrying an ID with them. The communication with the public was extremely difficult, especially that the media, and in this day and age, social media is really bombarding people with sometimes incorrect information in terms of this patient is in this hospital, so go see them, or providing inaccurate updates on in terms of response. So they were somehow creating additional chaos in terms of directing more bystanders to our hospital to try to ask about casualties and victims, and in terms of reporting of on the status of patients, which we really were not reporting during the initial phases because we were really busy responding. And you can see that this disaster happened during the COVID pandemic. So imagine us treating, usually we used to take full PPE for patients coming in with fever, cough, and suspected of COVID. And now you're suddenly facing hundreds of casualties. And really, there is no way you can continue to maintain isolation precautions except for wearing an N95. So the main bottlenecks that we faced during that response were related to the electronic health records that I talked to you about. Radiology, a lot of patients required head CTs, CTs of the chest and pelvis and abdomen, and these really were, we had a bottleneck there, and we had to organize the flow. X-rays were also important, and we had a bottleneck there. And this is related to everyone coming in with really deep penetrating injuries, and you had to identify foreign bodies, and you had to check for fractures and all this. The blood bank also really, the whole city actually was, we ran out of blood units, and usually we reach out to pre-hospital agencies, but the pre-hospital agencies really were also overwhelmed with requests. Fatality management, our morgue usually fits 10 patients. We had to, we had at one time 13 casualties. We had to reach out to pre-hospital agencies to try to arrange for mobile morgues. And this is something to think about in this type of disasters when you have a lot of casualties. So other hospitals faced even more difficult challenges. They had to evacuate their hospitals and at the same time treat patients. They had to care for patients and staff with limited resources. All their staff couldn't reach the hospital, especially if they were in the in the site immediately near the blast because of road closures and destruction. And there was a limited ability to transfer to other hospitals in Beirut. So I personally reached out to the Ministry of Health and to the Minister of Health and asked them to not send any casualties to Beirut hospitals across Beirut, and to start sending to rural areas. And this is what happened, actually. One hospital evacuated the 150 patients to a rural hospital, and they started treating patients in the streets. So you can think that this was starting to organize. However, we immediately realized that this exceeded the national capacity. And in similar incidents in the past, we have international presence, which is related to the UNIFIL and UN agencies and WHO. And the international, it really scaled up immediately to an international response. Within few hours, the government declared the national disaster. The initial resources that we received were related to search and rescue operations, and they focused on that. We had set priorities to care for casualties initially, and then to, at the same time, do a formal assessment and delineation of needs, because when you start having all nations respond, you really have to organize it. Otherwise, you end up with different teams that are working in an unclear manner, and maybe duplication of services, maybe working in the wrong terrain, or with the wrong agencies. So the Ministry of Health and the Army immediately were requested to set up a framework for all these responding agencies, and we immediately launched a request to them to try to prioritize the needs. Over 36 countries responded and international agencies. You can see that they divided the blast area into different colors based on agency responding. We set the priorities as a nation. We wanted the search and rescue operations to look for all casualties and missing persons. We wanted to supplement resources in terms of caring for immediate casualties, provide food and shelter for those displaced and for casualties, try to restore as fast as possible the capacity of the healthcare system in terms of immediately responding to casualties and continuing the response to COVID-19, and a quick damage assessment to be done to see what's still functioning and what's not. And we had received donations in equipment and stocks and supplies, but you realize immediately that these donations do not translate into an immediate dispatch and immediately reaching those who need it most. So they end up piling in stockpiles that, and the supply chain really suffers during these events. So our priorities were the immediate emergency care for the injured, ongoing assessment of health impact and humanitarian needs, coordination of the international response, continuity of the COVID-19 care, procurement of PPEs for healthcare workers, and provision of essential medical supplies to fill the gaps, and rapid restoration of the damaged healthcare facilities. So within the subsequent days, I visited different field hospitals. On the left, you can see the Russian hospital. It was their busiest service, believe it or not, was mental health emergencies. On the right, you can see the Moroccan hospital, and you immediately realize that the fastest people who would respond to the field are usually army or military hospitals, that they're the most set up, most equipped, and most capable of responding immediately. And that's why it is important for the army to lead the incident command structure, because they're most familiar in terms of dealing and organizing and dealing with other armies. Post-explosion impact on COVID-19, we had still the COVID-19 pandemic response happening. There was a mass gathering events that really followed this in terms of riots, in terms of displaced, and everyone really had a shift in priorities. So their main concern was the blast and not anymore COVID. And you can see that their public perception of risks was really, it really changed. Especially that no one cared anymore about COVID. They all cared about what happened. So eventually we had a really exponential rise in cases that lasted till last month. We also had at the same time, because of the destruction, a reduced capacity to treat COVID patients. So post-blast, we had new challenges in terms of mental health and social needs. We had the chronic rehab challenges. We didn't have any rehab centers before the blast, and now you have patients who really need chronic rehabs. COVID-19 pandemic continued to soar, and this was really very challenging. The socioeconomic crisis, which is really deepening until today, and it continues to deepen, really caused the continuous emigration of healthcare providers. The blast really nearly caused more than 30% of our healthcare sector to empty, and this because they had a sense of lost safety and security, and which was really exacerbated by the economic crisis. We continue to have protests and riots, and this continues until today. So, as a summary, really, the main lessons for initially. No matter how prepared you are, you can never be prepared for such an event. I worked for several years, and my focus area is disaster preparedness and response. I trained in emergency medicine, did my subspecialty in pre-hospital care EMS. I did so many drills with Boston EMS and with the different organizations. And when I returned to Beirut, most of my work was related to disaster response and pre-hospital care, but nothing really prepares you for this, especially when everyone who's responding is affected. So hospitals need to really, one main lesson is that we need to practice our evacuation plan and disaster response plan at the same time. So that really translates into, you have to identify an alternative site of care other than your EDs, other than your hospitals, because when something like this happens, really the main setting where you're most familiar with really is destroyed. You have to identify how to, and where to treat patients. There are limitations to EHR. No matter how streamlined you have your workflows with electronic health records, it's very hard to respond to such number of casualties and at the same time try to continue to work as if it's routine. We are now reducing the documentation needs. We're reducing the steps to register cases. We increased the pre-registered casualties to 500, but still, I'm sure when we reach this, we are going to face problems with hardware destroyed, with equipment, with everything. And you need to treat patients and then figure out how to document afterwards. Patient identification is a challenge in this setting, and it will continue to be a challenge unless patients come in and casualties come in carrying their names on their chest, or you will have to immediately devise a mechanism for identifying patients in addition to labeling them, and knowing who entered your hospital and who left, because you will get asked questions when you communicate to the public about the status of patients, about the number of casualties, about who's being treated and who's not. And really, until like after 10 days from this event, we continued to identify patients who were in the ICUs unconscious. We continued to deal with this. It took over 2 months for casualties to be fully identified across Beirut. Search and rescue operations are essential, and all the resources should be dumped into that field initially. Capacity building, really, you have to know where the gaps are. Our gap was really, how do you maintain a partly functional system until you get the international help? Like, no matter how prepared you are, it's similar to earthquakes. You need to call for help. You need to launch an international response, and you need to know what are your gaps until that international response arrives, and how you can try to start organizing the response in a way that when the international response happens and when it arrives, that it plugs in your gaps and it makes sure it works the way you have organized your response. So these are the main lessons we had. There are so many lessons, so many stories to tell, but really it cannot be told in one setting. But thank you for the invitation. I'm really happy to share this with you. These are my contacts. I'm happy to answer all the questions you have. So thank you.
Thank you very much, Dr. El Sayed. Awful circumstances, like you said, but we really appreciate you giving the talk. We've got a number of questions coming in. I'll just ask to begin with, how is your wife? Because you said that she was injured in the last.
Well, thankfully she found a motorcycle that took her. He didn't know her actually. He saw she was injured on the street. He transported her to our hospital. She did fine afterwards. It was a major injury to her leg, but thankfully she did fine. One of my plastic surgeon's colleagues took care of her. And it's really, she was lucky to have a plastic surgeon take care of her during that mass casualty incident. So,
I imagine
things happen. Yeah.
Well, I'm glad to hear she's okay.
Yeah, thank you.
Whilst we're just organizing some of the questions from other people, a couple from me. With everything going on, the chaos that ensues, you mentioned the huge numbers of people flooding into the ED. Under those circumstances, how on earth do you maintain any sense of order in that environment?
So it's really very hard. I mean, there is no order in that event. Everyone tries to help. everyone tries to address the first priorities they see, and usually the first priorities are saving lives. In this case, you immediately transition into a mode where you try to prioritize who needs your care first. We have a system in place. I mean, ideally, you have to have a leader in this setting to try to at least organize resources and dispatch them to different areas. You have to make sure that your team had practiced the plan and try to, as soon as possible, transition into a plan that everyone is familiar with. The most important part of the plan is really how do you distribute your casualties, to which areas, and assigning resources accordingly. This is the most important thing. I mean, you will be overwhelmed initially, but within few minutes, and as soon as the resources start to arrive, you need to know how to dispatch and where to send your resources to. Otherwise, you'll end up with chaotic scene. No one's helping. Everyone's trying to help, but at the same time, no one is helping correctly. So it's really important, one, to identify sections, assign resources, and to try to have someone manage the flow. So I mentioned earlier, like it's not enough to collect patients, you have to send them somewhere. So either you discharge them home, or you have to send them to the OR, and this really needs, all of this needs some flow management. And this is very important to maintain your capacity to treat patients. Otherwise, you will end up with hundreds of casualties in your ED, and you're not able to do anything, and it immediately overwhelms you. So you have to keep this in mind. Emptying your ED is as important as receiving casualties. That's why a lot of patients with minor injuries, we told them to come back the next day. A lot of patients who were injured, all of the patients who were injured and who were discharged, we told them to come back in 2 days to get checked. We identified, like all other hospitals, a lot of foreign bodies remaining in wounds that we had to clean. So this happens. I mean, this will happen. There's no way you can avoid this, but you have to do it.
Yeah, no, and I can only imagine that was 100 times more difficult given the amount of damage within different departments within the hospital.
And the absence of electricity. So yeah, there was no electricity. So everyone was using their phones to try to clean wounds and then suture them. And you can imagine the amount of debris that were left in these wounds at some point.
Unbelievable. We've got a few questions here from other people, so I'll try and work my way through some of them. So the first one asks, have you been able to work with Epic to improve the system during MCIs at your hospital and around the world?
So what we did is, it was a focus area for us, and we worked with them before the implementation. And after the implementation, we actually had a regional meeting with all the Epic institution in the Middle East, and we discussed this. We went back, we continue to improve it. We tried it, we tested it during the recent triads. It works fine when patients arrive gradually. I'm not sure how it will work when you dump immediately 200 casualty records on the system and you start using them. So we have to test it again. This is one of the drills that we're planning with Epic, but it requires extensive work in terms of recovery, also trying to clean up the system afterwards. But yes, we've been improving this. We told Epic and the Epic community our story and how we dealt with it, and we continue to try to streamline it further.
Thank you. Next one here asks, or says initially, thank you very much. And it's a huge list of thank yous in the chat from people who joined today. And asks, what requirements would you look for in an immediate alternative care site when evacuating the hospital? What kind of things are you bearing in mind when coming up with new locations?
So, I mean, it really depends on the mass casualty incident that you're dealing with. Ideally, it depends on your hazard assessment. So in our setting, we know that blasts are very common, and the equipment related to trauma and to dealing with injuries is what's needed. We have trauma carriages. In terms of setting, we really needed the tent and the trauma equipment. Other hospitals would face different MCIs. For example, there was a chemical attack, so you would need irrigation and decon units. So it really depends on the MCI. In our setting, Now we are thinking in a field hospital. We have a place designated for it. We have carriages ready to be launched to that field. And it's immediately next to our emergency department. Setting up that tent, I would tell you, unless you're the army and you're very organized and you have people 24-hour ready to set up that tent, it's going to take time, and it's going to be after you start receiving the casualties, because explosions happen and casualties arrive within few seconds and minutes afterwards. So it's really hard to time your setup immediately, but at least designate the space, know what equipment you will require initially, and then identify the flow and how you will send patients and receive patients in that. And most importantly is things that we really worked on after this event is how to coordinate with other hospitals. In this event, we couldn't coordinate with anyone. Everyone was affected. But really, if you're the only facility affected, then you need to be able to go on diversion or tell other hospitals to help. So before you reach the alternate standard of care that you would provide in the field.
You know, this is truly unique circumstance from the sense that so many of the other hospitals around were directly affected themselves.
I mean, it happens with earthquakes, but it never. I mean, even though Lebanon is earthquake prone, but thankfully we haven't had this recently. So, but this was similar to an earthquake in terms of damages to facility infrastructure.
And just leading on from what you said in response to that last question, where the things that you'll bear in mind depend on the nature of the mass casualty incident, to what degree did you understand what had happened in this event in those early stages? Presumably you didn't have the information that explained the source of this explosion.
No, we didn't. And actually, the blast wave really made everyone think that the blast was within their institution or within their house or within their neighborhood. And this is very common. I've never been in such a huge blast, and the suctioning mechanism that it has and the push-pull mechanism, you really experience it as if the explosion happened just immediately next to you or under you or above you. And this really made everyone think that the explosion was so close. So in terms of knowing what happened, it took, it actually, as soon as I looked, I realized it was an explosion, but I didn't know what type of explosion it was. Everyone was worried about the chemical impact on the environment and on people afterwards. But it was immediately decided that it's not that hazardous in terms of inhalation injuries. But at that moment, it took us around, like, I would say 10 to 15 minutes to know. And previously with blasts, we know immediately that there is a blast from the explosion. And our disaster activation plan, it activates based on the geographic location. So we have a perimeter drone on a map in Beirut. We know that if the explosion happens within that perimeter, we're activating regardless of what, because we will receive casualties. So this really happened in the middle of the perimeter that we had drawn, and it was a huge one. So we needed to activate. So it doesn't matter what type of event it happens. You have to be familiar that if it's a pattern, and if you realize that it's similar to other injuries, to other MCIs, then you need to activate the same way.
Yeah. We've got a question here which has taken a slightly different angle. How did you manage your own psychological trauma facing this mass casualty, not being able to treat all the patients due to lacking doctors and nurses? And from what you've said, that you're no stranger to these kinds of incidents. So, I imagine it's not the first time you've had to deal with it.
So I mean, this incident was harder than the others because I treated a lot of people that I'm familiar with, that I know, that are close family members, that are colleagues, friends, patients I've treated before. So a lot of patients were calling me by name. They were calling all physicians by name. They were trying to get in, get treated. I mean, you try to reassure as many patients as possible. My initial response was to try to assess quickly, make sure that those with life-threatening injuries were dealt with immediately. So, for example, when my wife came in, I immediately looked at her leg and I told her, "Okay, you're gonna go wait in that room, and I'll figure out how someone can take care of you." And then I disappeared like for half an hour. I knew that her injuries can be delayed a little bit to be treated in terms of compared to other patients.
That must have been
I
incredibly
went back
difficult to do, though.
yeah, but I reassured her, and I faced a lot of, it was harder to reassure, honestly, patients I would know and colleagues than my wife, because she somehow felt reassured and felt
Yeah.
safe when she arrived there. But again, your priority should continue to focus on the injuries. Somehow your training, all your experience, and everything you've seen in the past somehow translates into realizing that the priority is to care for life-threatening injuries and to assign resources to them. And then reassuring patients and reassuring their family members that they're being cared for. That was very important in this type of event. So, and it is very difficult. But immediately because you're preoccupied with action and we're trying to do things, you immediately, your head, it becomes, everything becomes automatic, and you start practicing what you're good at and what you've always done in terms of treating injuries, reassuring patients, managing flow, managing resources. And then you go back and check on people and reassure them more, and reassuring staff. Actually, the one of the very difficult challenges was trying to address the staff's morale, the staff's they're concerned about their family members that they haven't heard about. They're treating people they know, and at the same time they were affected, so a lot of them were injured and treating other injuries. So it's tough, but immediately you transition into that. So it took us a while, actually. Even now, when we hear a sound, it makes us think about the explosion. We're used to the wars, we're used to explosions, we're used to this event was different in terms of it happened unexpectedly. It made people lose their sense of safety, because they tell you stay safe at home. And no one was safe at that event. So until now, a lot of people left Lebanon because of that, and a lot of people are still looking for closure. But you just live to see another day.
Yeah.
And you're glad that you made it fine from that event. A lot of people lost a lot of people, so a lot of their family members. And you think about their situation, and it's much better than others. So that's why people continue to bear these events and then move on.
Yeah. Like you said, the geopolitical status there is very complicated, and people are still looking for answers, and there's understandably a lot of anger as well. You mentioned the lack of pre-hospital care and resources in Beirut. We've got a question here which asks, what level of pre-hospital care do they have? Are there dedicated ambulance services with EMTs and paramedics? What does it look like?
So we do have pre-hospital agencies. It is mainly the Red Cross, which is part of the International Swiss Federation. They've been generous over the past several years in terms of resources, donating to that agency. And most of the donations go to these agencies to support the volunteers. They rely mainly on volunteers. They have a good system. They're trained at the basic life support level. And the other big agencies is a national governmental agencies, also relies on volunteers mostly. So between them, they have enough basic ambulances. In terms of when I say lack of system, in terms of coordination between agencies, in terms of standardized pre-hospital care, in terms of medical protocols. But remember that these agencies survived the civil war, and they're very familiar with transporting casualties. So the system that they use is scoop and run. So in terms of transporting mainly the injuries, rather than field treatment. But with the riots, they improved a little in terms of setting up field tents and trying to treat casualties and avoid congesting hospitals. But during this event, and during any MCIs, you don't rely on the pre-hospital agencies first, because most injuries arrive by private mode first, and then by the time the ambulances arrive, the next wave of victims arrive that are usually more seriously injured.
And I recognise we're on the hour here. Do you happy to give another 10 minutes to answer a couple more?
Sure.
Brilliant, thank you. Obviously, like you said, you were very unprepared for this event. No amount of preparation that you had could have prepared you for what happened. You've talked us through in quite a lot of detail the protocols that you had and what you managed to stick to. Based off of how everything played out, with hindsight, is there anything that you think you as a hospital could have done any differently, or that you would do differently going forward?
So, I mean, it's a very tough question because it's not the amount of preparation that you have, it's how affected you are in these types of events. Yeah. So I can tell you, if we're not affected, we would practice our plan completely in a perfect manner. But if your hospital is completely destroyed, it's a totally different scenario you're dealing with. Now, all you can do is try to have a systematic manner in terms of what's the degree of damage you sustained, what are the available resources, what's your plan, and adjust your plan accordingly. You have to organize, you have to know how to organize quickly, but you have to be able to assess quickly and understand your capabilities in order to coordinate with other hospitals and other agencies. So if your hospital is completely, if our hospital was more affected, then we would have to ask to not send us any more patients, but if our hospital was completely prepared, we would reach out to other hospitals and ask them if the affected hospitals to receive their patients and their casualties. So it really depends. I think the most important element in this is having an incident command structure in place that really oversees how different entities are affected, what are the capabilities of the system, the overall system, and how you can support that. So in our scenario, usually, and in the US, it's usually it should be a lead agency. And that's why the Army didn't play that role initially, neither the Ministry of Health. All the agencies were trying, and all the hospitals were trying to respond individually. And by the time you organize this, you realize that your resources were unequally dispatched, or your resources were lacking in major areas. So ideally, the most important thing and going forward is to try to make sure that someone is overseeing the whole picture and really identifying who can respond and who cannot, and then accordingly coordinating between these elements. So this is really very tricky, and this is why we continue to ask that the incident command system be set up immediately during these events and not wait until everyone's overwhelmed, until things are not coordinated anymore, and everyone's struggling to varying degrees. So, and a lot of things you need to know, like one gap that we didn't know initially was how to leverage the community capabilities. So a lot of people helped everyone, like people who were bystander, who were in the non-medical field, they really were very helpful. NGOs were very helpful. So you really have to try to figure out who exists in your setting and what role can they play in such events. And then accordingly, when this event happens, everyone knows their role, so that they help support others, and they help really ensure that the supply chain, all the different parts of responses are taken care of. So one thing that I can really tell you that NGOs really help with is patient identification and victims identification and location. We really didn't have time as hospitals to try to figure out, continue to answer questions related to who's being treated at our facility when we're receiving 500 casualties. This could have easily been handled by different agencies that was overseeing tracking patients. And these are the capabilities that you want to build in your community, that you want to build in your setup, to try to see how other non-responding agencies can support your efforts to ensure that everyone's aware of the status at the event, and everyone's trying to coordinate things in a more organized manner.
Yeah, and you mentioned maybe you said a lack of awareness of how to utilize the community around you, and also earlier that social media played a complicating role in causing more chaos and directing human traffic into areas where it was already overrun. Do you think that possibly in the future there's a role for people within from the healthcare side of things, or the rapid response teams, to use social media to their advantage to direct that flow?
I mean, that goes back to how you set up your response. So having a clear incident command structure that immediately becomes the information source, the official information source is crucial during this event or other events. So people knowing where to get their information. So it took like 5 days or 6 days for the Ministry of Health to launch a site for missing victims and unidentified patients. And really, it's a long time to do, like it took them a long time to do it. This could have been done earlier, and it was done by some media outlets. But when you start receiving conflicting information from different sources, people really are looking for answers, and they want to find answers. And most of the time, the answers are not correct when they're sent on public in the media. So it is important to have to really designate your source of information during these events, whether it's a public health agency, whether it's the army, whether it's the structure that you have in place. So it's really important to, and that goes back to the 3 C's: care, communication, coordination, and providing care. So the communication part is really essential.
Yeah. And lastly then, if we wrap up with this, because I need to let you go and get on with your day. Obviously, this was only an additional burden on Beirut and Lebanon, on top of everything else that you've already explained was going on and has continued to go on. But to what extent has the healthcare system, I guess primarily, managed to recover from the direct effect from the blast? And from what I understand, Beirut port is the main port for the country in terms of import of goods and presumably healthcare resources and equipment. To what extent are you back to functioning where you were before?
I mean, in terms of direct impact of the blast, we were fortunate to have a lot of countries helping. A lot of people came in. Reconstruction happened quickly, specifically to hospitals, and agencies received a lot of donations in terms of trying to rebuild their capacities. The main challenges that we continue to face are related to the economic crisis that really made everything much harder. So you're still in a scenario where everything is not available. Even if you want to continue to operate back where you were, all the resources in terms of international healthcare supplies, everything is unaffordable at this stage in Lebanon. This is really draining all healthcare institutions, and they're really unable to charge patients more or to increase their revenues to cope with the increasing prices and the inflation and the Lebanese pound. So a lot of hospitals in the public sector are now, even the government is relying on funds and help from the external entities. The healthcare sector is still struggling, and we lost over 40% now of healthcare workers, and we continue to lose them to the external entities. And this immigration is really draining the healthcare sector. So to tell you the truth, this is like the worst situation to be in after the blast. Even though we recovered from the direct impact, the continuous impact of the economic crisis is really making the healthcare sector at the brink of collapse. So we still have to wait and see. But everyone's waiting for a political situation to help the economic situation, and this is up to the government now. So they know the situation. We are making sure that those who are accountable should be taking care of business as usual, so that we continue to operate.
Okay. Thank you very much for that, Dr. El
Thank
Sayed. It was a phenomenal talk. We really appreciate you giving us your time and talking us through it. Andy, did you
Thanks
have
a lot
any?
for the invitation. So
No,
I
we
was
appreciate
really
it.
excited to to give this talk to. I am, from my understanding, as you're from different countries, and it's really exciting to be able to share this. I mean, if you have any further question, I'm happy to answer them by email or.
There are a few others that we've got written down. So if you are happy to, I'll forward them on to you. And
Perfect.
Brilliant.
Thanks.
Did you have anything else you wanted to say, Annie?
No, I think I really just want to say thank you to Dr. Sayed. That was a very wonderful session. Thanks to everyone who joined, everybody, both from the African continent over here. I think I saw quite a lot of us here, and everyone who joined from across the world. Thank you so much. So over to you.
All right then. I'll let you go, Dr. El Sayed. Thank you very much for joining us.
Thanks a lot. Have a good day.
Have a good afternoon.
Bye.